Okay, hi everybody. Thank you so much for joining today's session. We are pre-health shadowing, and I'm Manasvi Sharma, the lead of Flag Sessions here. And today I'm here with Dr. Gerasio and my volunteers, Diana and Maham. So let's just start with a brief presentation about what pre-health shadowing is, and then I'll pass it on to Dr. Gerasio. Okay, so once again, thank you so much for joining today's session. We are Pre-Health Shadowing, an international student-led nonprofit for medical advancement. So throughout this session, we are going to have closed captions available to accommodate the needs of all students. And if you have any other ideas on how we can be more accessible, feel free to email us at info@prehealthshadowing.com. Additionally, if you want to stay in the loop, you can always sign up for our newsletter and follow us on social media. And here are our social media handles. And Maham should also be posting this in the chat. She is. So we host students from all over the world, and I'd love to know where you guys are calling from. I'm in California right now, so just feel free to type it in the chat. Canada. Ooh, another Canada. California. New Jersey. Georgia. Texas. Florida. Oh my God, this is a really diverse group, guys. Okay, additionally, if you're interested in being part of Free Hot Shadowing, you can do so by registering as a volunteer on our website, which is 100% remote. And to do so, you can just refer to the link in our chat. Other than this, we're also recruiting for our leadership team. So if you're interested in that, you can always apply, which is also 100% remote, by the way. And here are some of the available roles that we have. But other than this, if you feel like there's a role that we don't already have that will benefit PHS, we are more than open to suggestions. Additionally, if you are a high school student, well, that's wonderful because we have a high school training program called HCP, and it's offering leadership and healthcare education for pre-college learners. And for this, you can just fill out the interest form in the chat. Another thing is that donations are the foundation of pre-health shadowing, and we run solely of the time and donations of our volunteers. So if you could donate, it would be really, really grateful. And even if it's like $1. Throughout the session, you will have the opportunity to type your questions in the chat, and our co-host will ask them during the Q&A. Make sure to take good notes throughout this session because we are going to have a post-shadowing assessment available, and that just lets you earn a digital certificate verifying your hours. And lastly, it would be really great if you guys could turn on your camera because we're trying to make the session more engaging and trying to replicate a real-life environment. Now I'll pass it on to Dr. Razio, and you can take it from here.
Oops, I am muted. Wait. Okay, sorry. Okay, so I'm Dr. Durazio. I'm a neuropsychologist, and I'm going to tell you more about the field of neuropsychology and if you're interested in it, how to become a neuropsychologist. So I'm going to share my screen. One moment. Okay, and let's see. Hopefully that works. Okay. Okay. Can everyone see the slide? Okay, great. So what I'm going to cover today is basically who am I, my background, and what I do, how did I get here, and advice for pursuing careers in neuropsychology, which there are all different kinds, and then answer questions. So to start, excuse me, there's a little pop-up here. Okay. I'm Dr. Durazio, so I am a neuropsychologist, but I also wear numerous hats in my work. So I'm a clinical neuropsychologist, a clinical psychologist, slightly different, and I'll explain that. I'm also assistant clinical professor, actually associate now, but of neurology. It's where I work at the Keck Medical School. And I'm the director of the USC Cultural Neuropsychology Program. I also have a private practice. I do behavioral health consultation. I do speaking engagements, kind of like this. And I'm also an APA minority mentor. So there are lots of different things you can do in neuropsychology. So let's talk about what is neuropsychology. I feel like when I'm often asked what I do, I just kind of get a blank stare from a lot of people because they're not sure, they've never heard of it, and they often are like, okay, I just need to know what that is. So basically, neuropsychology is a specialty within clinical psychology, and it is basically dedicated to the understanding of the relationships between brain and behavior. So, clinical psychology often involves emotions and behavior and thoughts, things like that. So, neuropsychology kind of brings in what are the brain functions, the brain networks that are associated with the things that people talk about in therapy, but also we diagnose brain disorders, we assess cognitive and behavioral functioning, and we also help design effective treatments. So these are the kinds of clinical services that neuropsychologists can offer. So what I do, this is specifically from my career, I provide comprehensive, culturally informed cognitive assessment. So what does that mean? So when I have a patient, who's coming to me referred by usually a neurologist or someone in the MD often, there's a question about how their brain is functioning. They're either maybe experiencing some memory changes, behavior changes, that we want to know what is going on behind the scenes for it to explain some of this. Now, like we have MRIs that show us the structure of the brain, functional MRIs show us kind of like activity in the brain. Cognitive testing shows what different areas of the brain can actually do. And so we give a whole bunch of tests that are associated with different parts of the brain, and that's how we come up with our assessments. So I also do cognitive assessment with Spanish speakers and English-Spanish bilinguals. So the cultural part of the culturally informed cognitive assessment is acknowledging that, we all exist in a cultural context, and that often shapes how our educations, how we've learned, how we think about information, problem solving, our concepts of time. Like when I ask a patient sometimes to work as quickly as they can on this one task, that's going to mean something different for like various different people. So that's why it's important to be able to understand that when you're doing cognitive assessment with diverse populations. And then also to be able to do that with Spanish speakers or any other language other than English, because you can't just translate tests. You have to really make sure that, the concepts are also being translated and that what you're measuring is valid in both cultures and languages. So I work with that. I also have a specialized skill in cognitive assessment of individuals with limited or no formal education, which is a very tricky thing to do. So cognitive testing is often based on skills we picked up in school. So it's kind of like puzzle solving, math, there's some like verbal comprehension, verbal memory, visual spatial skills. So oftentimes I have had patients who come to me that have no experience in a formal educational setting. So they've never been to school, and I have to figure out how to assess their cognitive functioning because I don't want to confuse having difficulty on a test because there's actually something going on in the brain, or because it's just a lack of familiarity with tests in general or any kind of academic situation. So that's also a specialty of mine. I work across the spectrum of various medical conditions, so mostly neurology, but also oncology, so cancer patients who experience changes in their cognitive functioning, either due to cancer directly or because of the treatments. Autoimmune conditions, also like multiple sclerosis, psychiatry, various different psychiatric conditions are also associated with changes in cognitive functioning. Cardiology, pre-surgical and pre-transplant evaluations. So oftentimes when patients are sent to have an organ transplant or some kind of surgical intervention, they might be sent for a neuropsychological assessment to establish how the brain is functioning both before and after, but also to identify areas where the brain isn't functioning as well. For example, with seizure patients, I work with neurologists who need to identify the areas of the brain, both where the seizures are likely to be happening, so that they can do a surgical intervention. So it's very important to be able to measure brain function carefully in those contexts. And I also do psychotherapy. So I currently do this in neurology with patients who are living with chronic neurological conditions. I also have private practice where I see, general population. So those are the clinical services that I am involved in, but I'm also involved in academic research and consultation services. So what does that mean? Teaching and supervision. So I am involved heavily in training new providers, teaching medical students the things they need to know about neuropsychology for their board exams, and I supervise new neuropsychologists and kind of guide them on their assessments. Oops. I also am involved in research, and I'm a co-investigator, and I also consult for research, often involving Spanish speakers and cognition. So that kind of adds a little more interest in my work. I don't just do the clinical side where I'm testing people, but I'm also involved in research studies and trying to help understand, how the brain functions, especially across different cultures. I also do behavioral health consultations. So sometimes a company or a organization will ask me to help them with a specific question they might have, like doing assessments with a specific population. So I will do that kind of work as well. Also a speaker, like what I'm doing now. I do educational talks. I do these kinds of talks. And so that's a fun aspect of my work. And I do mentorship as well. So that in my work setting now at USC, I have students who are in the graduate program there who I kind of mentor through the process. I mentor them in research as well as in clinical work. Okay, so this is my path to getting here. And that is me when I got my PhD. And I put this here because I look very tired and I really, really blood, sweat, and tears on that one. So here we go. Because I feel like if you're going to make, the leap into dedicating yourself to this certain career, you really need to understand the steps to get there. So I was born a million years ago in the 80s in Brooklyn to Ecuadorian and Italian immigrants. So that is how I know Spanish. My dad actually was in Venezuela before he came to the US. So we grew up speaking Spanish mostly. And I say this because I think it's really important to think about like niche skills or specialization that you may have specifically from your life. So I took what I experienced as the child of immigrants as well as Spanish speakers and kind of had that guide my professional career development. I also am adding that I have a mild dyslexia, and I say this because I don't want people to think that if you have a learning disorder or disability that you cannot pursue a PhD. Like that is not true at all. Actually, I feel like the dyslexia helps me in my work because I kind of think more in patterns, and that is what I'm looking at when I'm getting all my data for, whatever neurocognition question that comes my way. So in high school, there was a lot of college planning going on. So I was kind of already thinking about going into a medical field early on. and I was valedictorian, which helps you when you're applying to college if you are one. Okay, then I went to Brown University as my undergrad school, and I started out pre-med and in the visual arts. Um, and then I had a change of plan. So I took a psychology course that I just needed kind of to fill my schedule. And I realized that I really enjoyed it on a level that was way different than just my straight up biology classes. And so it was really the interface between biology and behavior and thinking that was really intriguing to me. So I decided to kind of pursue more psychology, and then neuropsychology became an option for me once I had this job after college, after Brown. I went back to New York and I worked at Columbia University in their behavioral medicine program. I was a research coordinator, which means I ran their research studies. And in that process, we had some cognitive studies. And so I was able to kind of learn how to administer tests and interpret the data very early on. And so that overlap between psychology and neurology was really just super interesting to me. So I decided to pursue graduate school after that. Now, I ended up at USC, which, I never in a million years thought I would end up in Los Angeles or California for that matter. I was definitely thought I was a East Coaster, New Yorker that would never leave, but here I am now, many years later, I'm still here. And I think it's important to think about, where you go for your doctoral program, because that's where you end up making lots of connections and networks, and you want to really think through, like, is that a place you want to stay, or you have other opportunities once you're done to kind of relocate. But basically I sorry, I'm just moving this little window thing. Okay. So I entered a clinical training program and conducted research. And another thing to think about when you're choosing a doctoral program is whether you want to be more clinically focused, research focused, or both. And that really matters because it determines also how you would fund your doctoral program. So research programs tend to be supported by grants, and then they have fellowships that pay you to go to their program. Clinical training programs sometimes have that if they're both research and clinical, but for the most part, that would be more funded by yourself. So if that's something that you're thinking about in your pursuits for this career, you really need to understand kind of the cost of it all. And for me, I enjoyed research, so it worked out pretty nicely. I was able to get a fellowship and get my doctoral degree from USC, which then led me to my psychology internship. So at USC, my research was really focused on health psychology. So I was really interested in the psychosocial experiences of patients with chronic illnesses. And so a lot of it focused on cancer research. My dissertation was on the psychosocial adjustment of low-income Latinas to cervical cancer. And that was really my focus at that point. And then I moved on to my internship, which allowed me to expand that training. And I was able to also do my postdoc training there as well at the West LA VA. So that was a veterans hospital, very different from what I was used to, especially doing research with Latinas. So it's like mostly women. So big change. But it was a really valuable experience. I feel like I got a lot of diverse training there. Then the good thing about staying where you do your doctorate is that your connections can help you develop your career. So my mentor in neuropsychology, she contacted me while I was on postdoc and said, if you are looking for a job, we need someone at USC. And so I was perfect timing. It really worked out well. And I ended up getting a job as a clinical instructor, and also I completed my neuropsychology postdoctorate training there. So for neuropsychology, you need to have 2 years of a neuropsych focused postdoctoral training. And so that was my training. Oops. And then in 2015, I got my license, and I was promoted to assistant professor at USC Department of Neurology. And in 2017, oh, that's weird. Okay. 2017, I became the director of cultural neuropsychology. When I was there as a trainee and then as an assistant professor, I just noticed that there was a big gap. I was hired to do neuropsych assessments in Spanish mostly. They needed, to have their Spanish speakers be evaluated. So I just started to get asked to work on research studies with Spanish speakers, and it just became this thing where I realized, you know what, this needs to be an actual dedicated program so that we can help our patients have the most, the best quality care by having it be culturally informed. Um, so I started this program. This program provides neuropsychological assessment in different languages. It also provides consultation to researchers in our medical school, and it also provides training for other trainees, graduate students, medical students in cultural neuropsychology. And then lastly, most recently, I became the associate professor. So it's just in clinical academia, you kind of like move through at these professor levels. So that is where I am now. Okay. So another note that I want to make about diversity in neuropsychology. So when I started, this was it. There were like almost there are very few neuropsychologists who did any assessment in Spanish. So it was kind of like great timing for me. I was a bit of a unicorn, so I was able to be marketable in many ways. And the diversity hasn't changed all that much in the field. So this is from 2020, so things probably have changed more, I hope. But back then, only 4.5% of neuropsychologists identified as Latino, Latinx, or Latine. So, and that doesn't mean that they did their clinical work or research with Spanish speakers. That just means that's how they self-identified. So the number of Spanish-speaking neuropsychologists was even smaller. So another thing to think about is, what are needs in the field? So I kind of noticed right away that there was a need for Spanish language services in neuropsychology. So that's really what helped me kind of craft my career around. So I think it's important to kind of pay attention to those things. If you speak a language, other like Spanish obviously is very useful because I'm in Southern California and Los Angeles. It's very handy. But other languages are also needed. So if you speak something other than Spanish and you feel confident in it and fluent enough to do work in another language, I highly encourage you to pursue that as well. Okay, so I mentioned some of these steps, but I want to be very explicit about the steps it takes to become a neuropsychologist. Okay, so the first thing is, which I didn't necessarily think about when I was an undergrad, but it kind of worked out that way because I shifted my major to psychology. So there are undergraduate psychology requirements. If you don't take those courses in undergrad and you decide that you want to do this, you can do post-bac programs where you just take those courses specifically so that you can apply to programs, doctoral programs. Then there's graduate school. And graduate school is, I think it's really important to emphasize that this is a big time commitment. It can take as few, some people who are super efficient can do it in 4 years. I have never met someone who's done it in 4 years, but 5 years to 7 years. Once you're in graduate school, you're also older, so you might have some other life, commitments. You might be married, you might have kids, so things can slow down your progress. So you want to think about that and really make sure that this is what you want to do because this is a long-term commitment. Also, complete a clinical internship. So once you're done with graduate school, you've passed your dissertation, or you didn't pass it yet, but you're about to. There is like the last year of your graduate program is basically a clinical internship that you need to apply to. And usually these are done in medical centers or specific research centers. And depending on what you want to do determines kind of the kind of clinical internship you do. So I wanted to do something that was a little more clinically focused. So I went to the West LA VA in Los Angeles. It's a pretty popular internship. So it had a good track record, and it just covered all the areas I wanted to cover, that kind of gaps in my training from graduate school. And now there's postdoctoral training. So in different states have different requirements for licensing. So in California, you have to have 2 years of postdoctoral training, or at least one. I think it was back then, but now it's, I think, two, before you can be licensed. So you have another 2 years after you finish grad school to also complete a postdoctorate program. And that I did a postdoctorate program in health psychology because I wanted to kind of keep my options open. But then if you want to become a neuropsychologist, there is a specific postdoc that I'll talk about in a sec. So the next thing is you need to pass licensing exams. And so this, again, is state specific. California and New York and other, I'm thinking of like major cities that I'm familiar with, have licensing exams that have state exams as well as national exams. There's a national exam, and then there is a state-specific exam that focuses on like legal issues and ethics that are specifically to the laws of that state. So you have to get those exams done. And then for neuropsychology, there is a board certification that when I was coming up was kind of optional, and now it's required. So I definitely wanted to talk about that a bit. So that's where the 2 years of neuropsychology postdoctoral training come in, because you need to have that so that you can apply for board certification in clinical neuropsychology. For a long time, that was not a requirement. So, over time, it became clear that we needed to have some quality control over who's practicing neuropsychology. And so that's where the board certification comes in. So many steps, covers many years. So you want to really plan ahead. And then here's just like some advice that I have from, trial and error going through this process, because I will be honest, when I got, started in this, I didn't really know much about the whole process. Again, this is very classic for me, considering like first college educated person in my family. Like I wasn't exposed to the steps to get to different professional positions. So this was a learning experience for me, and I really would like to help people like avoid the pitfalls that I kind of had to struggle with. So one thing is you really want to take inventory of why you want to be a neuropsychologist. I've heard some people say, well, you make a nice living from it. Yes and no. It depends. So you don't want, the idea of that you becoming rich from it is, it depends. It depends. I don't want to say you get rich, but like you can have a very fulfilling career financially, stable career as a neuropsychologist, but it really depends. Like private practice neuropsychology, very different from working in a medical institution or having, like a different research program. All of those things are something to think about. And you want to think about timing and demand. Then we also have graduate program fits. This is a big deal. So you want, when you're researching graduate programs, it's important to really understand what they offer. Does that fit your career goals? And also, you're going to be working with mentors, different people throughout that process, and you want to make sure you have a good fit. So for research programs, or research heavy programs, you tend to apply to a lab to work with a specific person. And then for clinical programs, you tend to apply more for just the clinical program in general. And you may have like a one-on-one mentor for like a research project, but it's not as research heavy. So your research advisor in graduate school is a really important figure throughout that process. So you want to make sure you kind of, have a good fit with them, a good chemistry, understand your relationship, and make sure that they can help you achieve the different things you want to achieve. So that's something you definitely want to think about. Also, this is where all of your professional networks are going to come from primarily. And then it's also the quality of your life for the next 5 to 7 years. So if there are some programs that are known to be really, really tough, lack balance, and then there are others that are known for just, being easier, but also not helping provide too much support throughout the career development process. So it's really important to kind of know what you're doing there. I also feel like picking a topic of research that you love is really important. In graduate school, at least for research focused programs, this is the main focus of most of your time, the whole time in grad school. So you want a topic, you want a question that really, really pulls you in, is something you're excited about. Mine was generally cancer and psychology. So I was able to kind of carve out what I was interested in studying. But as I said, like my research was on psychosocial adjustment. It was not neuropsychology. So I always wanted to keep like a toe in neuropsychology because I knew I liked it, but I didn't really want to do research in it at first. So throughout my graduate program, I always took opportunities to do neuropsych training. So there was a chance to work as a tester in an Alzheimer's disease research center in our medical center. I did that. I just constantly tried to keep collecting training in neuropsychology, even though I was focused in health psychology during that time. And you know what? And it's also important to kind of be honest with yourself. If something doesn't feel like a good fit, it's much better to change earlier than later because it's a lot of time commitment. Quality mentors matter. I think I kind of mentioned this before with your graduate fit program. Everyone needs guidance through this process, and having a good communication, just a very clear understanding of expectations and, how you work together is really important. And then it's super important to develop and maintain a work-life balance. So everything is not about your career. Everything is not about work because you will burn out if that's how you approach it. Having balance, taking breaks is super important. In grad school, it's very easy to lose track of your work-life balance because there are so many demands of your time. And you're trying to get your dissertation done. I collected my own data for my dissertation, which adds more time. Some people have the option to use existing data sets for their studies, but I decided to just interview basically 300 Latinas who had cervical cancer, and that took a lot of time. So it was, having this balance will help you not get burnt out through the process. And now, not sure how we're doing on time, but I can take questions. I know that was like a lot of information. Hope it was helpful. Let's see. I'm just trying to open the chat a little bit. Hang on. I'm a little, okay, here we go. Okay. Where am I? Okay. What are some pivotal moments in your training that shaped your career path? Excellent question. So I think actually right after undergrad, when I was working at Columbia starting to do work in neuropsychological research, and finding that there were the diversity in the populations that were being studied was very, very limited. That was a pivotal moment for me. I was like, someone needs to be asking questions with more diverse populations. So one thing was that a barrier to that was language. And so I think that very early on was important to me. So I decided, I think I'm going to focus on that and see where it takes me. So I think that was a pivotal moment, which is why I emphasize kind of looking at your strengths and your unique abilities to find, these career paths that you may not have considered before, but really open up a lot of opportunities. Um, and let's see, for high school or early college students interested in neuropsychology, what experiences or skills should they start building now? Excellent question. So I didn't do much in high school necessarily to get to this point, but I think any experiences you can get either in the medical setting or in research. Volunteering is the best thing you can do, I think. I was like back then we called it candy stripers. I was a volunteer at a hospital, and that was really eye-opening. Basically, like sometimes, I mean, doing anything. Sometimes I was photocopying, sometimes I was just transporting patients. And it just gives you a sense of how you feel in that setting. Um, Volunteering for research, getting a sense of what is involved in the research is really helpful. So anything like that, I think. And to find those opportunities too, you can like obviously Google them, but you also want to just reach out to people who are already in the field, like even your own like primary care physician, and just see like, can you volunteer in the office or, whatever. You get creative with looking for opportunities. What originally drew me to this field? Okay, so I was originally interested in medicine, kind of always in neurology. So that is where it started. Then I took some psychology courses and I kind of got pulled in that direction because I really liked it. And then it was kind of like the marriage of the two fields that I found to be perfect for me. I should say, not a lot of neuropsychologists do both that and therapy, but it is possible. So I do both. Other people only do one or the other. So it's, important to think about that too. Was there a role model in your life who motivated you to pursue my profession? I mean, I think again, once I got involved in research directly at Columbia, that I had the people I worked with, the primary investigator, the principal investigators on the study, were really encouraging me to pursue graduate studies and kind of like cheered me on to do that. And because I wasn't sure, actually, I was still like unsure. So, so yeah. So I think the people I worked with early on definitely were my cheerleaders. Okay. When evaluating cognitive complaints, what neuropsychological patterns most reliably help you distinguish early neurodegenerative disease from cognitive impairment associated with depression or other psychiatric conditions? This is an excellent question. Someone knows their neuropsychology. Okay. So the key here when we're thinking about distinguishing, cognitive impairment that's linked to a psychiatric condition, we want, oftentimes we are diagnosing based on ruling out things. So in cognitive assessment, oftentimes the main question people present with is their memory is changing or something like that. And so right away you're thinking, okay, we want to rule out Alzheimer's. We want to see if there is a, vascular change in the brain, anything that could explain why that change is there. Now, some of those things can include depression or other psychiatric conditions. There is actually a diagnosis in psychology called depression with cognitive difficulties or impairments. So there's that, so where someone is so depressed that it actually comes out in cognitive difficulties. We see this a lot with older adults, actually, and sometimes it's called pseudo dementia. There are other psychiatric conditions that can also affect brain function. So, like, let's say PTSD or trauma, right? That can alter the way the frontal lobes of your brain, how they function in those networks. So you start to see difficulties with attention and focus, mental flexibility, things like that. So many of these conditions have a very specific pattern. So a neuropsychologist is trying to figure out, okay, what patterns does this, emerge in this data? and how much can we make it fit what we know about the patient, their medical history, psychiatric history, any clinical data like an MRI or EEG study of brainwave function, and then put it together with the data. So I hope that answers the question. Okay. And let's see. What is the most fulfilling part of my job career? This is my favorite question, honestly, because this is why I do what I do. I love helping people understand what is happening to them when they are scared that their mind is changing and their brain is changing. I like I just like taking what I know, figuring it out. It's a lot of puzzle, putting puzzle pieces together, which is definitely up my alley, but also communicating that to patients and helping them understand what is within their control, what is not, what they could expect with a specific condition, and how they can work around any weaknesses that we might find in the assessment. So I personally love that. Some people will come to me and be really worried about their cognitive functioning, and then we test them, and they're actually okay. And so even that, is enough for this person to feel like, okay, I know it's not my brain; it might be something else, like lack of sleep or obstructive sleep apnea or anxiety or things like that. So that's one part of it. Sometimes often you get patients who have neurodegenerative conditions, which means the brain is changing and it will continue to change over time. And so that's like Alzheimer's, vascular dementias, Lewy body disorders, Parkinson's, multiple sclerosis, like all of those conditions affect the brain. And being able to give patients information to understand their conditions and to help them and their families or whoever's taking care of them understand how what to expect, how to help them improve the quality of their lives, that is the most rewarding part of my job. And also translating research for people who like my patients and their family members. I think that's something that we don't really talk about a lot in the field, but there like science literacy is really not great right now in our country, and I think helping people understand what we know about different conditions is super important. Okay. I'm just going in order, so I hope I'm not missing too many. What are some common cultural or linguistic factors that can lead to misinterpretation of neuropsychological test results? Excellent question. Okay, so I've had this happen a few times. I also do research in Mexico, and this came up a few times where it was fascinating because the research battery that was designed for some patients was really focusing on tests that were very verbal focused. And this is the population I was specifically studying, which tends to have higher rates of this early onset Alzheimer's. For some reason, they're in these hot spots in like Guadalajara and like Jalisco. So folks in those communities tend to had kind of limited levels of education in those specific towns that we were studying. And so we're testing them and expecting them to kind of like adapt themselves to all these verbal tests that we're doing. And sometimes I just felt like in speaking with them, I'm like, why are their test scores low? But they don't seem like they have a cognitive impairment. And so once we added more nonverbal tests, we started to see a difference. We started to see strengths that were not there originally. Also, in just observing them, this is one of the things I brought up about understanding how people conceptualize different behaviors. For example, working as fast as you can. Like I had an older woman who I told her, I need you to connect these circles in order, and they were like numbers in them, and I want you to work as fast as you can. And she just like kind of like really took her time doing it. And I was kind of like, Um, and her original score would have been in the impaired range. And then I had her do it again. And this is not like standard administration, but just because I had that feeling, I'm like, this is not assessing the right thing. So I told her, when I say as fast as you can, I really mean like the fastest you can do. And then she was like, oh, okay. And then I tried to explain it as much as I could. I'm like, imagine it's a race and you want to win the race. And she said, okay. And then she did it and she was in the normal range. So it's just a matter of like really being able to communicate. And that's the thing I love about cultural neuropsychology, because you kind of have to think on your feet sometimes. A lot, I mean, it's still super limited, even for Spanish speakers, and for other languages even more limited. So the tests we have are limited, the normative data we have are limited. So you really have to know what you're measuring and how to measure it so that you can do it in a valid way. um, so, yeah, another common linguistic issue is that some people will just translate tests literally from English to another language, and it's not an appropriate translation. Or they'll use translators, which introduces a whole different element to the assessment. Now you have a third person in there, and if they're not familiar with what, like neuropsychologists are measuring, they may not translate things accurately. Um, I think that's kind of like where I went with that. Okay. Yeah, most of the misinterpretation it comes down to is is this pattern of performance consistent with a neurological condition? Is it consistent with the patient's level of education and exposure to formal academics? Is it consistent with their linguistic ability? Things like that. Another thing is sometimes I'll have a Spanish speaking patient come in and want to be tested in English. And I'm kind of like, but that's not really going to help us understand how your brain's working if you think in Spanish. So I often ask people, what language do you think in? What language do you dream in? To really make sure we're like approaching this assessment as authentically as we can. Okay, sorry, I'm like saying a lot. Okay, where are we now? Okay, in patients with temporal lobe epilepsy, what cognitive patterns most strongly indicate involvement of medial temporal memory structures versus lateral temporal language networks? Okay, so a very specific question. So I love it. Okay, so epilepsy patients with temporal lobe activity, right? So temporal lobes are, kind of like located above your ears, and they house a lot of different structures. They house the hippocampi, which are where memory are stored. And then it also has language structures in there. So, like verbal fluency, semantic verbal fluency, things like that. So, what to distinguish those, you have so if we're talking left, I think it was right. Okay. Left temporal lobe. Am I reading that right? Okay. Well, let's start with left because we could do both. So left is more verbal, right? So we would give measures of verbal memory, different kinds of measures too. Usually we give narrative memory tests, so reading stories. And then we do a list learning task, which is the gold standard of memory testing. And so the stories require someone to process information quickly and pick out the important information and hold on to it over time. But the information is presented in an organized way. So you don't have to really make the information organized. It's coming at you organized. So that's one thing. The word list test, the words often seem random, and it's usually like 15 to 16 words, and you learn them over multiple learning trials. And that kind of testing gives us a lot of information. It gives us learning strategy. It tells us whether you group things by categories or just like rote memorization. It also tells us if you have if you're able to learn more at each trial, are you able to hold on to that information? And then it tells us whether you have difficulty consolidating that information, meaning putting it away, or retrieving that information, which is, different. So I would definitely do verbal memory measures to measure left hippocampal function, which is in the temporal lobe, and medial temporal lobe specifically, actually. And then for the language networks, in the lateral temporal lobe, I would primarily do like semantic verbal fluency tests. Also, a phonemic fluency test, which I'll explain why. So semantic verbal fluency is category fluency. You give someone a category, they tell you all the things they can think of that belong in that category. So they have to access information, words semantically. That's housed in that left temporal lobe. So phonemic verbal fluency, which is someone gives you a letter, you have to say all the words you can think of that start with that letter. And you do this with multiple letters. That's actually more associated with frontal lobe function, so left frontal lobe. So you give both because you want to distinguish the two if you can, and then also verbal memory measures. If we're thinking about right medial temporal lobe function, we do visual memory measures because that's where that lives in the right hippocampus. So, measuring memory is tricky because we have a natural tendency to verbalize information. So, let's say there's a complex figure and you have to remember it or you're drawing it, most people are like, oh, it looks like a house. It looks like this. And that's how you remember it. Now that's no longer just visual. It's a combination of verbal and visual. So we try to give tests that are like show in, stimuli very briefly so that there isn't a chance to verbalize it. You really just have to look at it and try to remember it. So based on the performance on those different tests, we can kind of distinguish, what part of the temporal lobe is functioning either a little better or not. Sometimes you don't get, clear information, and that's definitely happens. But that's typically how we would try to do that. What else? Okay. What was your undergrad degree in? Also, if you had to do this process again, starting from undergrad to now, what would be your advice to yourself? Ooh, very deep. So my undergrad degree was in psychology. So, but because I wasn't sure exactly what to do with that after, I also took kind of like your basic pre-med courses. So biology, organic chemistry, the really super fun stuff. And just so I had it in my back pocket in case I wanted to switch to medical school. But that was what my degree was in. And I was also involved in research as an undergrad. So I volunteered for research studies so I could learn about how to actually do the research, even though, I wasn't sure if I was going to do research, but I just wanted to have as much information as I could. And starting over, what would I tell myself? I think I would, the questions I kind of posed before about really understanding what I want to do, I would encourage myself to do that. I would look very carefully at programs and what they can offer and what they do not offer, and if I'm okay with that. And also having a better understanding of the timing and all of the hoops required to jump through to get to the end. I mean, full disclosure, as an undergrad, I kind of was like a go with the flow kind of person. So I wasn't thinking ahead all that much. I just knew I liked these topics, pretty good at them. I think I can handle them, and took it from there. But there are definitely people in my program that were like knew every step of the way what was coming. So I think I would have encouraged myself to be a little more proactive in looking ahead versus just getting to each step and then kind of like winging it. Okay. Got a lot of questions, so I'm going to try to answer these a little quicker. Do you observe measurable executive or attentional deficits in patients with frequent interictal epileptiform discharges, even in the absence of overt seizures? Yeah, you do. I think it depends, but so this is asking that there are epileptiform discharges, this meaning like the brain discharges in an EEG or something like that, that you'll see on the screen without visible like convulsions and things like that. Oftentimes, what you see is executive or attentional deficits, where you don't see the actual physical symptoms. It does affect the cognitive function depending on where they're happening. So if they're happening in the frontal lobes, for sure, but sometimes they kind of jump around. So they will start in one part of the brain. Let's say the left temporal lobe is a very common place. And then it kind of can like go forward into the frontal lobe, or just affecting that part can disrupt the neural networks that connect the frontal lobe with, other parts of the brain. So yeah, I do think you can see measurable executive and attentional deficits in those patients. These are great questions. Okay. As our understanding of the brain evolves, how do you see the role of neuropsychology changing in the next decade, especially with advances in neuroscience and technology? Very good question again. So one thing that I know is coming up a lot in neuropsychology is streamlining the efficiency of, of assessment. So when we think about a cognitive assessment, typically it involves a neuropsychologist or someone trained in neuropsychology, like an assistant to a neuropsychologist, administering tests that can take up to like 9 hours. And then that person has to score everything and interpret the results, comparing it to normative data. And that's all very time consuming. So one question that constantly comes up is, can we computerize things? Can we use AI to assess patients? And, some neuropsychologists are a little resistant because that kind of gets rid of your role. But I think they can coexist, because the computer assessments can just do what they're programmed to do, but there are definitely nuances that an observer can have that can put those computerized like data into context that the computer doesn't necessarily know. For example, in my department, they were trying to get an AI like assessment using a tablet, mostly for screening, but I knew it was kind of to develop into testing too. And the neuropsychologist in the department got to observe, the administration, and it was a time task, and the person taking the test sneezed. The computer doesn't know that the person sneezed. So now it took them longer to finish because they sneezed, and they were like looking for a tissue. Like it was a whole thing, they're looking for a tissue. And so that's why I feel like you're still going to need that human component. Also, I think AI can help with interpretation. I use it sometimes when I'm having a question and I'm like, I just debate with it a little bit. I'm like, what about this? What about that? And then it actually, kind of changes its conclusion. And so I think it helps us kind of refine diagnostic impressions. It can help us do that. But I definitely think that the two can coexist. And I think that's the direction we're going in. So the goal is to save time, but not compromise quality. So that's why I think humans have to still be involved. I guess that's maybe the next question. As machine learning and computational neuroscience progress, how might these developments influence neuropsychology? Yeah, I think it's more just making it more efficient. I would love for someone to score, my tests for me. Like computerized scoring is fantastic. But the ultimate interpretation, I think, has to involve a neuropsychologist or someone trained in it. Okay. In patients with multiple sclerosis, what neuropsychological patterns most reliably reflect white matter network disruption, particularly in domains such as processing speed and executive functioning? Okay, so when we're thinking about processing speed and executive functioning, we're thinking frontal subcortical. So we would, for multiple sclerosis, it's usually associated with lesions in the brain and the spine, depending, on the presentation. And so we are thinking that we're going to want to test processing speed. The classic test we do is a kind of like a coding test where there are numbers and symbols, and someone has to write in symbols that go with each number. That's a typical part of a multiple sclerosis neuropsych protocol. So that things like that we would definitely give. I would like to give cognitive flexibility and mental tracking tests as well. These are all timed, and I think that's an essential component to this because the main thing with frontal subcortical conditions is that it slows down your processing speed. So you want time tests, you want tests that involve switching like systems. So basically switching categories, if you're doing a fluency test, alternating between numbers and letters on a trail making test, things like that. That's what I would definitely give. Um, I just had a multiple sclerosis patient where I did this, so that's good timing. When evaluating patients with multiple sclerosis, oh, another one. Okay. How early can neuropsychological testing detect cognitive changes before they become functionally apparent in daily life? Okay, that's a great question. And it's still unclear. So it depends on who you ask. I think once patients start to have functional impairments and they think back, they're like, you know what? My cognitive functioning changed a long time ago, and I just didn't notice it. So it's kind of hard to say, but I do have patients who present early with cognitive changes, and there's this mystery, process where no one knows what's going on yet. And then they start to do more testing, and it starts to emerge that there are markers of multiple sclerosis. Other people have more functional presentation first, like motor issues, and they may or may not even develop cognitive changes just depending on where those lesions are. So if they have primarily like lesions in the spinal cord, then that's not necessarily going to present with as much cognitive change as if they have them in the brain. Some people only have them in one spot. So, that's kind of part of it. So how early, it just really depends. But yeah, because you can present with either symptom first. I wish there was a clear-cut answer because that would really be helpful. Okay, how could you best market being bilingual for yourself, and how could you find opportunities to help out people within said community that may speak the language that you speak? Perfect. Love this question. So I think on the training side, I think you want to get as much experience as you can doing the services you're going to be doing with speakers of that language. Because being fluent in a language is different than being able to do it professionally. So I would encourage folks to like assess their language fluency. And if you need to improve it, you can. Don't give up. You just do some like extra medical focused training in that language, and also just language programs that are focused towards medical professionals. They exist. And to market yourself, I mean, you just constantly say you're bilingual to anyone who's going to listen. Because as soon as you say you're bilingual and like anyone finds out, they're like, oh my God, we need that. We need you. We need you in this context. We need you in this one, center or whatever. So you just have to make it a part of your professional identity. Help out people within your community. Oh, okay. So for me, like specifically, like Spanish speaking, I get a lot out of helping the community. A lot of that comes from direct clinical care. A lot of that comes from education in the community too. So helping them learn about what to look for, what are signs of dementia. Sometimes people just think memory change is normal, as you age, which some of it is, but and they overlook, early signs of like Alzheimer's. But there are lots of organizations too, like condition specific organizations, even the places where you may work that have community outreach. So you might want to connect with them and see if you can, reach out to the communities that you're interested in helping. But I think that work is really important. Okay, what's the most rewarding part of working with multilingual and diverse populations? Well, I love providing a service that is very limited access to. So that's one thing. I feel like I can help people who are not getting help. I can improve the quality of their care because I actually speak their language and have the cultural, like bicultural experience of understanding, their experiences probably. So I think that's really important. And there is nothing like the look on a patient's face when you meet them and you're speaking to them in Spanish and they have not had a provider speak to them in Spanish, and if that's their language, right? And so um, it's like you just see this, like this relax, like they just get relaxed. They feel heard, they feel seen. It's very rewarding. So I think that's part of it. And I just like to help my community too. As you get older, like, I don't know, my parents are aging. My mom actually had a stroke not long ago. And so for a neuropsychologist, that's like one of your worst nightmares. And so getting to take what I've learned and like use it in my own family, helping others by like being able to share those experiences. I do find in my multilingual and diverse populations, I share more of my personal experience than I think typically happens in the field. I think it's important. I think that's how you connect. And I think that's part of many cultures. So, it's different from the standard Western medical model where it's like there is this distance between you and the patient. I kind of try to keep that distance very limited because I think you get better information. You just provide better quality care when you are a little more open. Okay, it's most reward. Okay, wait, I just did that one. I'm diagnosed with various forms. Okay, I'm diagnosed with various forms of autonomic dysfunction, dysautonomia, and my current plan as a pre-med is to become an autonomic neurologist. Excellent. Do you see patients with that and talk about your experiences with that? Interesting. Okay, so I am so happy to hear that you want to go into that specific specialty. I think there need to be more people in those specialties who actually understand what it's like to experience the condition. It's hard to understand, let's say, someone with like Alzheimer's if you don't have it, and because you just can't have dementia and provide clinical care. So in this case, though, you actually can. And I think it's just striking the balance between being able to share your experiences with someone and understand that their experience may not be the same. And to know which parts of it you can pick out and use to help your patients, and which parts, may not be as helpful. Because let's say your condition is not as severe as your patients, then you're just kind of highlighting like how bad it is for them. But you can say, you know what, I've been through that myself and I understand, the process could be similar, even if the severity is different. So I do think it can help. But I do think being careful with making your clinical service, making sure it stays about the patient and not about you. Like the patient should not be taking care of you. If your experience helps them, great. But just kind of keeping that in mind. How much of your time is split between clinical practice and research? Good question. And what do you do to maintain balance in your life? Okay, clinical practice and research. The lines get very blurred sometimes. And, this is where it's important to keep track of what you do because if I'm not paying attention, I end up spending like 60% research, 60% clinical, and obviously that's more than 100%. So, I do. So there's on the practical side, the way my salary is structured, I'm paid off of grants for research, and then my clinical work is paid through the clinic. So that's like charging insurance and things like that. So I know how much percentage effort I have on these grants so that I kind of reserve for the research. So for me right now, I'm doing like 40% research, 60% clinical, and it kind of flip flops sometimes. But basically, as long as you're providing everyone with the services and information you need to, you should be okay. Because some aspects of research, I'm just consulting more on the front end, and they don't need me throughout the whole process, or front end, and then when they're ready to start analyzing data. So in that time, I might have a little more clinical work going on. So it just depends. And I'm on like at least 10 studies. So, it's a lot of juggling and keeping track of, where you are with which study and your time commitment. Um, and, if you're not careful, basically a good thing to remember is that working in medical, especially academic medical settings, if you offer to do work, people will never say, no, you're doing too much. You have to be the one to watch what you're doing because it's kind of like whatever you give, people will take. So you want to make sure you monitor that. And then now going into maintaining balance in my life. So I try really hard. I have some boundaries that are solid. Like I don't work on weekends. Um, During the week, I try to finish by the end of the workday, like 5 or 6. Doesn't always happen because sometimes a report needs to be done earlier or whatever. You get these last minute requests. So, or writing, publications and things like that, you end up working later. I thought I didn't want a career that had homework, but I ended up having a career with a lot of homework. So, you know, um, so for me, it's very important to maintain that balance, to make sure I get rest and exercise and like eat right. It's not always perfect, but I try my best. Because if you're not taking care of yourself and your body, like you're going to burn out easily. So I also see a therapist. I have my own therapist. I think that's important for mental health providers to have their own therapist. It is not easy to be telling people they have Alzheimer's regularly. It's not easy to tell someone they can't, they are unable to do something now because of changes in their brain. So you do need to have a support network. I have a group of psychologists who I meet with weekly, and we discuss cases, we discuss life, just like regular, just support. So I think that's how I maintain balance. Um, Also highly recommend playing tennis if you can. I get a lot of like satisfaction from playing tennis. Okay. What professional organizations or conferences do you recommend for someone? Okay. So there is the National Academy of Neuropsychology. It's called NAN. And there is also the International Society, sorry, I'm like blanking now. INS, International Neuropsychology Society. And so those are like the main groups that have conferences. So INS is kind of like the main one. And then there's the American Academy of Neurology that also provides neuropsychology, information and conferences and things. So those are the main ones. But INS actually will host um, postdoc interviews and things like that. So if you have to go to those conferences if you're applying to certain postdocs because that's where they do their interviews for it. So that's definitely something you need to look into. And I actually like to go to conferences where it's not necessarily neuropsychology focused, like APA, the American Psychological Association, because what they cover, they have neuropsychology components. And it's interesting to see what they're focused on too, because you get a sense of like, what does the field need right now? And so sometimes we can get lost in our little niches, like when we stay in neuropsychology. I also like attending neurology conferences, which often have a neuropsychology component, often have cognitive research. So there's that. I'm also part of the Hispanic Neuropsychological Society. So that helps me with like specifically like Spanish language and like Hispanic like cultural issues. Very supportive group. Highly recommend if that's your niche. Yeah, I think those are the main ones. Okay, when working with underserved wait, did I skip one? No. Okay, when working with underserved populations, what strategies have you found most effective for reducing healthcare disparities in cognitive care? Ooh, great question. Addressing disparities is tricky, and I think most of it is best addressed in community education. I think having regular involvement in community activities, going to community centers, caregiving groups, whatever it is to kind of provide information helps with the disparities. I think information is power, and a lot of underserved communities and populations just don't have access to information, either because they can't actually physically get there or because of language barriers, things like that. So I think the most important thing is to provide information and get it to those populations. I also think there's some part of the work that you can do if you you're so inclined, that is like, pro bono, low cost, just to make sure to improve that access, because it's really hard sometimes, and we try so hard to reduce these disparities. But like I said, there are just some things that, like, in some cultures where we think, memory decline is totally normal with aging, they or certain symptoms are not associated with brain changes, but they actually are, that might be mistaken for psychiatric issues, like behavior changes and things like that, that you might see with like Lewy body disorder. There are all different kinds of things that if we just brought that information to these populations, they would have a much better understanding and be able to look for these things and connect with the right resources. I also think there's a lot of case management that can happen to help with disparities, meaning people who directly work with individuals in the populations to help them kind of coordinate care. Like this, you go to this doctor, you go to this social worker that will help you find resources for like caregiving, for example, and then like help kind of organize that. Sometimes it's super overwhelming, especially if you have just natural barriers like transportation or linguistic barriers. So I think those are important ways to try to reduce disparities. That's a big issue, though. So if that's something you're interested in, research wise and clinical service, amazing, excellent. There are almost always, well, now I'm hoping still, like funding for that kind of work. People really are interested in reducing disparities. As a neuropsychologist, does your research need to revolve around your clinical work practice? No, not necessarily. I mean, so the research I'm involved in is kind of across different dimensions of like neurology. So I'm mostly in Alzheimer's, but I also work with epilepsy research. I also work with MS researchers as well, and motor disorders like Parkinson's. So it I work with those patients clinically as well. So there is overlap, but there are some people who just focus on Alzheimer's, but still clinically work with patients from across the neurology spectrum. So it does not necessarily have to like overlap entirely. Have you seen any research findings that challenged your assumptions about brain function or cultural differences in cognition? Yes. Early on, I think. I remember there was some research done in communities or populations that were much like not nonverbal, but their communication wasn't based necessarily in the same structure as Western languages. And that was one of the things that I found eye-opening, was when you started their performance on a lot of tests was impaired, but once you had them do like nonverbal tests, like nonverbal intelligence estimates and things like that, they were fine or better. Like it's just kind of like, how do we define these skills? And like we have to keep in mind that a lot of neuropsychology was based in, research done in Western, primarily white, primarily male populations. And those are where the definitions started. So we just need to keep in mind, like I read research about IQ testing, and like how people tried to justify different IQ levels of different cultural groups or racial groups, and how methodology was terrible in these studies. And it's just lots of assumptions and things. So I think um, that's the kind of research findings that I found that were fascinating, and also, challenging a lot of like what we're taught about brain function. Um, Also, like, like bilinguals might perform more slowly on fluency tests because they have more information in their brain, like more words in their brain. So they're trying to switch and access two different libraries essentially of verbal information. And so that used to be interpreted as like bilingual people having lower IQ, which is kind of like, very contradictory to what we know. And so that kind of research I think is really interesting. A lot of it is kind of connected to like language too. Oops, no, I did not. Okay, what is your take on psychogenic non-epileptic seizure disorder? Yes, which is now called functional neurological disorder. Um, do I believe it's commonly misdiagnosed due to other causes, not being ruled out first? I was misdiagnosed with it, and then after a tilt table test months later, yeah, okay. The vasovagal syncope with convulsive seizures is what the seizure-like episodes really were. Interesting. Yes, I personally find psychogenic non-epileptic seizure disorder fascinating, because it just, to me, emphasizes the power of our brains on, our bodies. And so I do think it's commonly misdiagnosed. I think it's often ruled out late, because we're trying to rule everything else out, and it's typically a diagnosis by rule out. But because I feel like medical providers are constantly looking for the explanation for things. They also are not great about understanding some of the other predictors of having this. You tend to see functional neurological disorders kind of pop up in some populations that experience trauma, things like that, where they just don't even think to consider that. And I like, people who have POTS, the positional issue, or like what you just described, the tilt table test. I mean, like, you would think they would try to do that early to figure out, what this could be. So I do think it's misdiagnosed often, and it's misunderstood often, because sometimes people think of it as like a conversion disorder, which it's not necessarily, or they default to it because they just can't figure it out. And I don't think that's fair either. I think distinguishing the biological cause from a psychiatric cause is limited. I don't think that's an accurate representation of how our brain works. So I think there's just a lot of old thinking that gets involved in why that is misdiagnosed often. And it is a stressful process. I feel like I get patients often during that process because they don't know what to do with these patients, and they're like, oh, let's do neuropsych testing, like, just to see. And then honestly, I think this having the clinical psychology component to it, which is just really knowing what questions to ask, kind of can help clarify some of it. So I'm sorry that you had to go through that. I've heard so many stories though, and it's really unfortunate. How often do I see patients? Right now, it depends. In the neurology clinic, I see patients 2 days a week where I'm on site, and then I work from home, hybrid, so on the other days, but I am seeing patients just remotely. So when I see patients face to face, it's mostly to do the actual assessment. And then when I see patients remotely, it's either for therapy or for feedback sessions after testing. And so I see patients most of the week, actually. So it's like 3 days. I kind of fit research in around my patients. So that's kind of like my priority, is to see patients first. I hope that answers that question. What quantitative metrics or approaches are most useful for identifying deficits in functional connectivity, and how are these measures translated into clinically meaningful insights about neuropathology? Okay. Deficits in functional connectivity are interesting because, like, there are new imaging procedures and approaches that can give us like really amazing results that kind of show actual neural networks. I don't know if you've seen these images. They're like, it's like the shape of a brain, but it's all these colorful like strings. It's called the spaghetti, like image. And I think that is an amazing quantitative metric for identifying, gaps or like breaks in functional connectivity. Also, I mean, technically, the cognitive testing should correlate with that as well. But I kind of feel like you need the additional clinical data from like imaging to kind of put that together. Um, and I think it's actually super meaningful for neuropathology because I do think that it's given us insights into the extent of these neural networks that we thought were very limited and like very specific. And that actually, there's all the networks kind of overlap. It's a lot in there. And I think some people thought, oh, language was just this one network, and it's definitely not. Yeah. So I'm not sure how we're doing on time.
Yeah, we got like 5 more minutes. That's fine.
Okay. Okay. These are great questions. Okay. Given the growing use of digital cognitive assessment tools and AI, what challenges do you foresee in the ensuring these tools remain valid and equitable across multilingual and multicultural patient groups? Excellent question. I think, well, this actually came up. So when my department was considering this AI measurement and screening tool, I asked, so there is like, the researchers and the doctors and the providers, and then there are the companies that create these products, and so, we had this company demonstrating the product for us, and just aside from just the whole like multilingual aspect of it first, it in real time I saw this not score the actual test accurately, and the response from the company was that, oh, but you can look in the date, there's deeper data that you can look into that is accurate. But I'm kind of like, if this is making my life easier, I don't understand why I would have to do that. So that's one thing. So AI, it has to be accurate, it has to be reliable. And I have now seen like maybe 10 demonstrations, and maybe twice there wasn't an issue like during the demonstration that we were aware of. So that's problematic. So I guess training the AI is really important, and to train them with like different patient groups, multicultural, multilingual. So the same company, they were like, do you have questions? And I asked them to try to run the program in Spanish because I was curious about what it would look like. And the test that they were trying to get done was like just a clock drawing test and then 3 words. So they read 3 words to you. You had to remember them, draw a clock, and then recall those words. The words that were in Spanish were like company, industry, and like daughter. It was really random. And I was kind of like, well, is this like education like adjusted? Because if like, because those are just like really weird words just to begin with in English, let alone in Spanish, so they did not have an answer for that. So that was concerning to me, that they may not always have the awareness of the influence of language and education, and how these systems really need to be stratified, by those things, and like designed to adjust for those things. So yeah, those are the challenges that they're going to keep working on, I'm sure. But honestly, I have not been in I haven't seen super reliable outcomes. So I'm still waiting for them to kind of make me feel calm about using them. And I have yet to see that. So, okay. Given the growing use of digital cognitive assessment. Oh, I just did that. Okay. What was your undergrad degree in? Oh, I did that. Okay. To piggy off the back of this, do you think those bio and chem courses were beneficial, necessary for your neuropsychology career? Yeah, I do. I think the bio courses for sure, because if you're thinking about, medical conditions, you have to understand the body. So that's definitely helpful. There are neuroscience courses definitely are relevant, and I would highly encourage you to take those. The chemistry courses are beneficial in the fact that they just train your brain how to think sometimes, like just the logic that you need to use to figure out some of these problems is similar to logic you need to use in data analysis. So I think they're beneficial. Yeah. When would someone see a neurologist or psychiatrist versus seeing you? Okay, good question. Oftentimes people see a neurologist or psychiatrist first, and that's when they talk about these issues because many people are not aware of neuropsychologists. So the neurologist, I get most of my referrals from neurologists. Sometimes I get referrals from psychiatrists who are concerned about cognitive difficulties they're seeing in their patients. So it tends to be I'm like the last person they tend to see, which is interesting. But if you think about it from like a clinical perspective, you always have a referral sources. So that's kind of a good thing. Okay, any final questions? I guess we're out of time. These are excellent questions, by the way. I'm feeling like I'm sensing some future neuropsychologists here, which is excellent. And please, feel free to reach out. I'm happy to connect, talk to you about this more if you have specific questions. I'm based in Los Angeles, but I do have, connections in other areas. So please feel free to reach out.
Thank you so much, Dr. Rosario. And I just wanted to say that we really loved hearing about how you approach neuropsychological assessments with just like such a thoughtful and also culturally informed perspective. And also thank you for just telling us about how you connect research, clinical work, and also advocacy. And I think it gave us a lot to think about as we explore our own paths. So,
Great.
yeah.
I'm happy to have provided that. It's
Mhm.
always important.
And let's just do a quick wrap-up presentation about pre-health shadowing. And feel free to stay back if you have any questions.
Okay.
Hey everyone, so I have three questions for you, which is what were your favorite moments or examples from today's session? What's one idea from today that you're most excited to explore next? And what's one key takeaway or idea that stood out to you the most? Feel free to answer these questions in the PHS website reflections. Other than this, you can always share your insights about today's session on LinkedIn by tagging us at prehealthshadowing.com. Once again, if you're interested in being part of the pre-health shadowing team, you can join our leadership team or volunteer with us, and it's 100% remote, so you can do it from the comfort of your own home. And it would be really great if you guys could donate. You can do this by money-wise or donating your valuable time with us through volunteering. And don't forget to take the digital assessment today after attending the session. It's just a simple 10-question multiple choice quiz, which is based on today's session with Dr. Rosario. And if you missed part of the session today, you don't have to worry. You can visit our YouTube channel on Pre-Health Shadowing and watch any of the previous session and today's session for free. Make sure you sign up on our newsletter or just check the PHS website regularly to catch up on our sessions every week. The next session is on March 17th. And thank you so much. Feel free to stick around if you have any questions. Thank you so much, Dr. Azurio. It was so nice to see you.
You did. Thank you for having me. It was really fun. Okay. See if there are any questions.